Hello, and thank you for joining me for number 6 in an 8-part series, The Essentials in Oral Health, exploring topics in preventive dentistry and periodontology. Sponsored by Johnson & Johnson, this series is offered exclusively to members of the Next DDS user community. I'm Greg Psaltis, your guest speaker for the evening, and it is certainly my pleasure to be here with you. For 3 decades, I have been a pediatric dentist, and I have enjoyed every minute of it. And it is my great pleasure to have the opportunity to talk with you this evening on this topic. I've presented topics on preventive and pediatric dentistry all around the world, and was honored this year at the Chicago Midwinter meeting with the Gordon Christensen Speaker Recognition Award. This evening, we'll be reviewing the importance of oral hygiene for the pediatric patient. And I'm looking forward to not only sharing the important pieces of this topic, but also stories with you about things that have happened to me in my own pediatric practice. But first, a couple of housekeeping items. This webinar will run for about 45 minutes, and you can pose questions to me at any time using the tool at the bottom of your screen. I'll collect them and address them as many as possible during the presentation or afterwards. So now, without further ado, let's move straight into the presentation. The importance of oral hygiene for the pediatric patient. I have to tell you, as a pediatric dentist, this is a topic that is very, very near and dear to me. We want to be exploring these issues of pediatric dentistry so that you are more prepared to deal with your population of young patients. And by the way, if any of you have any concerns about young patients, let me reassure you, they can be some of the best patients you will ever have. The learning objectives for this evening's presentation are to review the importance of pediatric care and the trending in children's oral health. We want to discuss early childhood caries, which, as we will discuss, is a major issue in today's world. We want to highlight the role of oral hygiene regimen and fluoride in caries prevention. And last of all, we want to reinforce parent instruction and recommendations for compliance, because clearly in the pediatric population, you must rely on the parents to be able to bring forth much of the health for their children. So people sometimes ask me, well, what is the importance of pediatric dentistry? Well, I could spend hours talking to you about that, but this evening I want to talk about the role that tooth decay can play in the pediatric population. Among other things, and again, we could talk for a long time, but among other things, it's painful. Studies have shown that children with high caries rate have an impact on their schooling, their ability to work well in school. Of course, some of us would say that treatment is challenging. I might not say that myself, because I believe treating children is a wonder. However, many people will say that treating children is a challenge. And of course, the other thing that we have to consider is that caries in primary teeth can impact the permanent teeth. There are children who have come into my practice who are preschoolers who have told me about how children in their preschool have teased them about the way their teeth look. So aesthetics is a question. When you have large caries that are interproximal, they can become a space consideration. There are many aspects of caries in pediatric dentistry that must be addressed. And as a result, when we are seeing our patients, we must really be careful to identify the children in our practices who we consider to be at risk. So often people will say to me, well, why are we treating primary teeth? They're just baby teeth, aren't they? Well, yes, they are just baby teeth. However, few people really consider that those only baby teeth will be the ones that will do all of the chewing of food up to the age of 6. And some of them, in particular the posterior primary teeth, will be present up until the age of 10 to 12. So this is an often overlooked part of the importance of primary teeth. The other piece is that they help to develop the jaws, and they guide the permanent teeth into place. Early loss of primary teeth can lead to space problems and orthodontic difficulties. So the new standard of care is that children should be seen when their first tooth erupts or no later than 12 months of age. Now, for some of you that might come as a surprise, But believe me when I say to you, this is becoming the norm of dentistry. Those who think that this seems too early, I would offer these three words to you: well, baby, check. There is no parent on the planet who will not identify with the words, well, baby, check. Everyone takes their babies in to the pediatrician, and soon it will become a norm for children to be seen by dentists when that first tooth comes in, or before the age of 12 months. The American Academy of Pediatric Dentistry is very clear about the fact that we want to be establishing a dental home for children. If the term dental home is something that is new to you, then I'd like to explain what that is. A dental home is really, it's a term that we use for a way to provide comprehensive care. So it's less of a place and more of a concept. When we have children coming into our practice and creating a home for them, this is because we are able to see them on a regular basis. We are able to do comprehensive examinations. We are able to treat them in a fashion that is more conservative. We can do dental prophies. We can recommend fluoride supplementations. And we can also provide one of the most important things, and that is self-care instruction. Now, self-care instruction is actually quite a bit greater than just brushing and flossing. It includes talking about some of the things that are nutritional and caries, and well, the foods that will create caries. So right now, we find, surprisingly, when people say to me, well, gee, aren't caries going away in children? Not really. The current landscape is that this preventable disease continues to affect an unbelievable number of children in the United States of America. Now, the children who typically are most affected are those from low-income families. There are certain minority groups that are affected more commonly, and of course, there are children with other healthcare needs. It is so important to make sure that the healthcare and the care providers are given all the information so that they are prepared to prevent the problems so that we are not having to treat the problems. This is conceivably the ultimate prevention. So you might ask, well, we have more dentists now, we have more insurance now, we have more ways that people can get to the dentist, so why are we having this problem? Well, the real problem is not with all of the population. The real problem is with the vulnerable population of children. And these are children who have a number of things that will make their oral health more at risk. For example, when we have populations of children who are at higher risk for caries, they will have more needs that are often unmet. The other problem is that they may have limited access to care, not because so much that there are no dentists to treat them, but because sometimes they will have care providers who are either unaware or unable to bring them into a dental office, not realizing the importance of early dental care for these children. The other thing is we have some geographic problems. As a rule, many dentists coming out of the dental training programs will want to go to, quote, desirable places to live. And sometimes these desirable places may not be where some of the at-risk population actually reside. And as a result, we have a bit of a miss. We have patients who are living in places where there is not adequate manpower to be able to handle the needs. And last of all, we have federal insurance programs now. And with the Medicaid eligible patients, we are finding that fewer and fewer dentists are willing to accept these patients. So as we're looking at this screen and we are seeing that there are a number of issues for the vulnerable population, we can appreciate the fact that many children, in spite of what appears to be living in a country with fabulous health care, actually will find themselves not able to receive the care that we would like to provide for them. So what are some of the implications? Well, when patients do not have their health care needs met, there will be, of course, more dental caries. There will be more untreated caries. There will be malocclusions, and of course, children with special health care needs often will not be seen. Now, as we're looking at this slide, we can see a young child that has primary anterior caries, and we see this very commonly. I live in Olympia, Washington. It is basically a white-collar community. It is the state capital of Washington. And some of my fellow cohorts that have been working in this community with me for years often say to me at my local dental society meetings, gee, do you actually see a lot of caries anymore in your practice? Well, the answer is yes. I see caries in my practice every single day. And I believe that my community is not necessarily one that is particularly heavy in a vulnerable population. I have a relatively sophisticated population where I live, and in spite of that, we see children like the one you can see pictured on your screen right now every day. And it is very surprising to me, and for those of us who are dentally aware, and of course anybody in dental school will be very dentally aware, it's hard to imagine that what you're looking at on the screen can possibly happen given all of the preventive regimens that we have available to us today. Well, I am here to tell you that what you're looking at on the screen is everywhere. It doesn't matter where you live, it is everywhere. And when you have children like this, it can result in either physical or psychological suffering. As I mentioned earlier, I have had children that come in who are preschool children, who go to daycare centers, and they will tell me that the children at their schools tease them because their teeth are dirty or brown or possibly looking just like the ones you are seeing on your screen at this moment. So we're sort of beginning to move now into the concept of early childhood caries and the challenges that that poses for pediatric dental care. Early childhood caries is something that has probably largely driven the reason for the recommendations to see children at a very early age. When the American Academy of Pediatric Dentistry initially came out with their recommendations to have children seen at the age of first tooth or under 12 months, I was skeptical. I thought to myself, why are they doing this? I don't really know what we're going to do with these patients. I'm not really sure how this is going to go. How can we examine these children? I can assure you that even as a very seasoned practitioner, I myself had quite a few issues with the idea. But when the time came that I was working in the operating room on a general anesthetic case on 3 children in a row who had rampant early childhood caries, it finally struck me. I said, you know, what would it have been if we had seen these children when their first teeth came in? Instead of waiting until they have problems to care for, what if we had seen them earlier? So some of the challenges in pediatric care is not seeing the children early enough. And as a result, we really want to make sure that we are doing everything we can to inform parents to give them the opportunity to avoid early childhood caries. So some of the challenges. Well, let's look at this. Early childhood caries results in severe decay, and we are going to look at some pictures of some severe decay very shortly. The teeth break down. Sometimes they are broken down to the point where they cannot be restored, and this is really tragic. It's a particularly virulent form of caries that spreads very rapidly, I believe, for a number of reasons, among them the thinness of the enamel on primary teeth. As you begin to look at radiographs of primary and permanent teeth, you will be able to appreciate the difference in the thickness of the enamel. And when you get bacteria working on that thin enamel of primary teeth, I assure you it can go very rapidly. Interestingly, in spite of all of the efforts that our wonderful profession has made toward prevention, dental caries remains the #1 chronic disease affecting children in our country. That to me remains a shocking statistic. However, it is true. So why is this? Well, largely it's because of the fact that caries are dependent on the frequency of refined carbohydrates in children's diet. And in my practice, what I find is the relationship between sugar and decay now seems to be fairly well established in the minds of most people. However, the two concepts that really are not so well understood are the frequency of ingestion, and number two, the actual physical form of the carbohydrate. In other words, if a child has, for example, raisins, then what we have is an apparently nice, healthy snack that is very rich in sugar because it started as a grape and is now all the water is sucked out of it, and it is physically adherent to the tooth. So there are a couple of factors here that really result in dietary considerations. We have children that have very high carbohydrate diets. Carbohydrates, as a rule, tend to be some of the least expensive foods available, so they become a bargain to buy, but they are not necessarily a bargain for the teeth. So now we begin to look at some pictures. And the picture on the left is the picture that I like to see. I can assure you that after 39 years in my specialty, I do not need to be filling more teeth. I have filled all of the teeth I ever want to fill. So when we have a child come in who looks like the one that is on the left side of your screen, with nice, smooth surfaces, with beautiful pink gingiva, and those nice spaces between the teeth, this is the picture that I want to see on all of my patients. Of course, that is not the picture I always see. Now we're going to move to the right side of your screen, where we're looking at carious primary teeth, and these teeth are indicative of early childhood caries, and we are talking early childhood caries here. You can see some of the decalcification, you can see some of the darkening. All of these are indicative of weakening enamel and possibly decay. So, is there any good news to be said about this? Well, the good news is that sometimes, if caught early enough, these lesions can actually be reversed. This will largely be through the use of fluorides and home care, and we will get into more detail about that in just a moment. But now, look at these pictures. These are the pictures of children that I actually see in my practice almost on a daily basis, recalling now that I am not always dealing with a vulnerable population. Look at the child on the left side of your screen where you are seeing some brown spots or they're dark spots. And these are areas that are probably not so aggressive, but nevertheless, they are carious and they are going to need some kind of care. And if you can catch them at the point that you are looking at on the left side of your screen, this is not a difficult procedure. However, as you let your eyes go to the right side of the screen now, and we are seeing severe early childhood caries, we are seeing teeth that are very, very severely broken down. And when they are at this point, the care for these, of course, becomes more expensive, more time-consumptive, more difficult for the child, more challenging for the dentist. These teeth are, in every way, a greater challenge. Now, the other thing that is often overlooked is that primary teeth can also abscess. Now, fortunately, nature has somehow provided for children that when primary teeth abscess, it is not unusual for them to be asymptomatic. Pretty much the opposite from permanent teeth that create among life's greatest agonies. However, even primary teeth can lead to significant pain, or in the worst of cases, they can lead to a facial cellulitis. And when you have a young child with a facial cellulitis, I can pretty much assure you that you have a very sick child who is potentially now in a health crisis. Not just a dental problem, a health crisis. So, how do we deal with this? Well, one of the ways we deal with this, and one of the tools that has become pretty much the standard of care now in pediatric dentistry, is that we really want to do a comprehensive risk assessment. Now, what does that mean? Does that mean doing an oral examination and saying, wow, this child has a lot of decay, so he must be at high risk? No. We are now doing a much more thorough examination to really look at other factors that are taken into effect. So among them, there is a socioeconomic inverse relationship. The lower the socioeconomics, the higher the caries rate. The higher the socioeconomics, the lower the caries rate. But other factors that don't immediately meet the eye are that the primary care provider's caries activity becomes a fairly good way of judging the child's risk. Why is this? This is because of the transmission of the bacteria from the mouth of the primary care provider to the child. These particularly occur at a couple stages of life when the child is no longer on a bottle, for example, and they are switching over to a sippy cup. Oftentimes, the primary care provider will actually demonstrate with the sippy cup for the child. This is how it works. And they will take that sip, and then they will turn the sippy cup around and put it into the child's mouth. And so now the bacteria that existed in the mouth of the primary care provider has been transmitted to the child. The second time that this is quite commonly occurring is when the day comes that the child is having its first food. Then the parent will often take that spoon, dip it into the applesauce or carrots or whatever that food item may happen to be, demonstrate to the child, this is how we eat the food from a spoon, and they will actually eat the food. Then they will take the same spoon, dip it into the food, and offer it to the child to eat. Once again, you can see that we have a direct transmission from the primary care provider's mouth into the child's mouth. So this becomes a significant factor. When we have children coming into our practice, we will often want them to, we want to make sure we coach them in this regard so that they learn that they should not be sharing tippy cups, they should not be sharing spoons, they should not be sharing those sorts of things. Some of the other risk factors include premature low birth rate, children with special care needs, children who bottle feed, and are eating sweets or starchy snacks more than 3 times daily. Now, I mentioned to you earlier that sometimes we will have the frequency of eating will be a bigger factor than the actual food item itself. So that if a child, for example, is having some kind of a snack and they eat the entire snack at one time, it will have less effect than if they eat the same amount of snack in small increments. So at this point, we have a very nice question that's come up that I would like to address. And that question is this. They say, what kind of alternative snacks do I suggest to parents who have been feeding their children high-carb diets, especially when they say their children are picky and underweight? Okay, first I would like to say that when I comment on this, I'm going to answer that question exactly like I would in my own practice. And when I answer it, it may sound to you as if I am either harsh or hard, and I want to make it very clear that I am neither. I am an advocate for children. So when parents say to me that their children are picky eaters, what that tells me is the child is now dictating to the parent what the child wants to eat. And I must say to you that it is inappropriate for parents to let the children pick their diet. And even though, again, I want to preface this by saying I do not want to sound hard, but when I tell a parent either give them a good snack or give them no snack, and the child will quickly learn to eat something good. So what alternatives do I recommend? Do I recommend broccoli to a 3-year-old? Of course I don't. What I recommend are real fruits, not fruit roll-ups. I do not recommend that they give them bread all day long. I recommend that they give them, if the child is capable of chewing, nuts are an extremely good snack food, non-cariogenic. So there are actually items that you can recommend, in particular fresh fruits that most children tend to like grapes, for example, are a superior snack than a raisin. And if you can give them things of that nature, I think that the children will learn that these are things that are really not being forced upon them, but are actually quite enjoyable. So I really do appreciate that, that the question has come in, and I hope that answers it at some level. Once again, what I mostly do is encourage the parents to take charge. If the child is dictating things, we can be pretty much assured they are not going to pick the things that are the healthiest. Now, when we have a risk assessment, I've only given you some of the items that are sort of the high risk. But what you see on your screen right now are some of the tools that are available from the American Academy of Pediatrics, the American Academy of Pediatric Dentistry, and the ADA. These are charts that will actually help you to determine what the risk factors are. And you'll notice that they have low risk, medium risk, and high risk. And even though the print is very, very small, what they are talking about is the low risk are the children who have few snacks or don't have a lot of starchy snacks or whose parents have a low caries rate. And the people in the high risk category are the ones that don't brush, don't have fluoride, etc. So these are the things that, that we feel are so important to determine when you are establishing the risk factor. And I encourage each of you to look into the American Dental Association, the American Academy of Pediatric Dentistry, and look for these tools, because they will definitely help you to assess the risk factor of a patient, and that will largely dictate how you will deal with that patient. Now, when we have children at high risk, what we really want to do is be making all of the preventive tools available to them. Now, on the screen right now, you are seeing the two words called self-care. Well, self-care does not mean that the child is doing this by him or herself. What this means is caring for oneself at home. So children should definitely have their teeth brushed a couple of times per day, twice daily, with a fluoridated toothpaste. And clearly, when the child is very young, this is not a time for them to be trying to brush by themselves. And quite frankly, I've had parents come into my practice who I look at them and their dexterity may be questionable, and I will encourage them to use any means to clean their child's teeth, especially when you have nursing mothers who are getting up at 3 in the morning. I don't believe it's realistic to expect them to be able to find a toothbrush and brush their child's tooth. So I say you can use a cotton roll, you can use a Q-tip, anything to clean the teeth after each feeding. The professional applications should come when they come into your practice, and these can be in the forms, as it says, either in fluoride varnish or gels. Varnishes, as a rule, are getting more and more publicity as being the preferred method, and we found them to be quite effective. Studies have certainly shown that they are effective, and there are many ways that we can actually use some guidelines. The American Dental Association has guidelines for these. And I think that if you are uncertain as to what the best way to do this, please go to your professional organizations that have this information available. Now, some of the challenges in feeding. Breast milk actually is one of the healthiest things that a child can have. It is the most nutritious. It provides the nurturing between the mother and the child. It provides the antibodies for immunity. There are so many things about it. However, it can become cariogenic if it is in combination with a carbohydrate diet. So as I mentioned a moment ago, we encourage the parents to always make sure they wipe the teeth clean after each feeding. And I've had 3 children of my own, and I know that nighttime feeding is never an easy time to do this. But unfortunately, nighttime is also the time that all systems slow down, including salivation, which is one of the ways that caries can be neutralized. And so we really want to make sure that we have no substrate sitting on the teeth at nighttime. So another question's come up, very nice question. Can I explain fluoride effects after the teeth have erupted? Well, after the teeth have erupted, there are actually studies that indicate that the main way that fluoride works is on a topical way. And we're going to be coming to that in a moment on a slide. But basically, once the teeth are in place, the topical effects, the fluoride will actually combine with the hydroxyapatite crystal and will create a harder surface that is more caries resistant. So we are finding that having the topical effect is very critical, either through the fluoride varnishes, the gels, the toothpaste. All of these are ways that fluoride can be delivered to a child to impart that physical hardness to the tooth and make it more resistant to decay. Thank you for the question. There are many oral habits, and these habits can include thumb sucking, finger sucking, pacifiers. All of these things can change the shape of the mouth, can open the bite, can lead to some speech problems, can narrow the palate. There are a number of issues that have to do with when a child is a finger sucker or a pacifier user. So in my practice, I try very, very hard to get children off of their oral habits as soon as reasonable. Now, children with pacifiers, in my practice, I try to get them off absolutely as soon as I possibly can. Thumb sucking is a little bit more complicated, but once again, we do not want it to be ongoing, in particular up until the time that the permanent teeth are erupting into place. Then thumb sucking has the possibility of changing the orthopedics in a child's mouth. And orthodontists can straighten teeth, they cannot straighten bones. Teething is a question that comes up very commonly because when children are beginning to get their teeth, or either they're breaking through or about ready to break through, it is not uncommon for children to have teething pains. Now, the parents, what they will notice is increased irritability, increased drooling. Some studies have shown that there is an increase in diarrhea. There are a number of things that go on because the child is literally in pain. One of the things that is a more recent development is that we do not recommend that people put any kind of a numbing solution on the gums because of the fact that the child can swallow it and get an inappropriate amount of that drug into their stomach. So instead, the recommendation is to use chewy toys, or sometimes I will have these toys put into a freezer because the coldness will actually have a numbing effect, and as the child is chewing, it will tend to relieve that pain. Another question has come up about when should we begin with fluoride toothpaste. I'm actually coming to that very shortly. So thank you for the question. If you'll just hold off for a moment, we will be getting to that in just a moment. So anticipatory guidance is a very nice phrase that has been coined in pediatric dentistry. That what it really means is that we are giving information for people in advance of the problem. So when we talk about all of the dietary considerations and the habits and so forth, what we're really trying to do is help parents to understand that there are potential problems that we are trying to proactively avoid. So this is one of the great changes in dentistry, that as a profession, I am tremendously proud of the profession that we are arguably the only healthcare providers who really have put into place a real prevention program. And with young children, this program has now been ramped up to include all kinds of things. We've talked about some of them already: the oral hygiene, dietary counseling, fluoride therapy. All of these are things that you see on the screen that fall under the aegis of anticipatory guidance. And what that means is we want to guide people so they can anticipate what is coming next. And under these circumstances, many of the things that become problems don't become problems if you have an attentive parent. And frankly, that will vary quite greatly. You'll have some parents that will hear everything you say, and some parents who, on the basis of their child's dental health, appear to have heard nothing. However, that should never, ever discourage you from giving everybody your best. So let's talk a little bit about the importance of the oral health regimen and fluoride for the pediatric dental patient. This is coming back to the question that was asked a moment ago about what happens with the fluoride after the teeth have erupted into place. Well, fluoride can be delivered in a number of ways. You maybe happen to live in a fluoridated community, so that the child could be drinking fluoridated water. However, nowadays we have more people who are drinking bottled water. We have people who have all kinds of strainers on their tap. A number of different things make it somewhat suspect as to whether they're actually getting the fluoridated water supply. I live in Olympia, as I told you, and Olympia, Washington is not a fluoridated community. So here in Olympia, for my patients to get fluoride, it becomes essential that I actually write a prescription for them, especially for those high-risk children. And of course, we also have the fluoridated toothpaste, so that there again we have that topical effect that I was talking about a moment ago. This is largely why it becomes so important for the children to have toothbrushing each day, because it gives not only the cleaning of the teeth, but the topical fluoride effect. So here we're talking, once again, I mentioned this earlier when the question came up, that we have the calcium and the phosphate to form fluorohydroxyapatite, which has greater acid resistance. So really what the fluoride is doing is it's providing an actual physical hardness that will make the tooth harder to penetrate when the bacteria touch them. It also affects the physiology of the dental bacteria, the strep mutans. So there are a number of different effects that the topical fluorides can have that will be very, very beneficial for the child. So here again, we're getting back to the idea of we want to make sure that our patients have the fluoride supplementation in some fashion or another. And it can become complicated if you live in a fluoridated community. Well, do I give fluoridation, the fluoride supplements or not? That is something you must be very, very clear about. My area actually my practice draws children from as far away as 100 miles. So in Olympia here, we have to make sure that we know every community that is fluoridated and not fluoridated in order that we are able to appropriately recommend fluoride supplementation or not. Finally, we come to the question that was posed a moment ago, that basically when a child is under the age of 1, we want the teeth to be cleaned either with a soft toothbrush or, as I mentioned before, if we find a parent who does not appear to have a lot of dexterity, sometimes I have some concerns about them being able to use a toothbrush in a squirming 9-month-old. So I will encourage them to use whatever they can. They are better off using a cotton roll or a Q-tip or a washcloth, anything that they can do to clean a tooth off. Of course, the toothbrush will be the optimum. When the child is 1 or 2, the parents want to continue brushing the teeth, and when they get to be 2 to 3 years of age, we want them to brush twice a day, and now we're beginning to use a small amount of the fluoridated toothpaste, as you can see on the screen. We call it a rice-sized amount. In other words, just a very small dab. And when the child is over the age of 3, then we go to the pea-sized amount. Unfortunately, as we make this recommendation, we are fighting against the ads that people see on television where there's that large blob of toothpaste put all the way across the bristles, which is way, way too much for a pediatric patient. And one of the key things here is always have the child brushing with parental supervision. Because sometimes, in particular with this day and age of good tasting children's toothpaste, the children will think of it as being candy, and they will actually eat this stuff. And then, of course, that becomes a source of over-fluoriding or over-fluoridation. Flossing, very, very important. The reason we recommend that people start flossing around the age of 2 to 2.5 is that is typically when that second primary molar begins to come into place, and it will create a contact point that needs to be flossed. Interestingly, statistics show that the majority of primary tooth decay is interproximal. So interestingly, flossing children's teeth becomes a more important preventive step than brushing the teeth in terms of just removing food and debris. I believe there are a lot of factors for this. Again, the thinness of the enamel, the breadth of the contact points. There are a lot of reasons, but basically we want to make sure that parents understand that flossing is also a very critical piece. When we tell a parent your child has 6 cavities, I cannot tell you how often they say, I don't understand it, we brush his teeth all the time. Well, congratulations, but unfortunately none of the areas with decay are brushable. The areas that are decayed are the places between the teeth. So many times we recommend the parents do this for the child until the child has adequate dexterity, often around age 8 to 10. They really cannot do it even with the cute little floss holders that are made. So these are things that the things that we really want to make sure that the parents are aware of in order that we can get the areas that are at points of contact totally cleaned. Now, in terms of how we treat children, this is a lecture that I could do for 3 hours, and you'll be happy to know I'm not going to. However, the absolutely totally basic rudiments are, you want to use the show, tell, do technique where you're telling children in advance what they're doing. Like adults, children do not like to be surprised. So if you can tell them in advance what's coming, then you will have much better luck with them. Use very simple terms. In my practice, we blow sugar bugs with my whistle. We don't remove carious areas with my high-speed handpiece. That does not work. We're constantly providing appropriate positive reinforcement to make sure the child understands what is expected. And when they perform, tell them so. Children love positive feedback. These are all ways that we can modify their behavior and find that children are excellent patients. So the other thing is, once again, going back to the risk factors, I want to really underscore the importance of that. I want to make sure that people who are listening understand that once we understand that children who are at higher risk or lower risk, that will affect how often we take radiographs, perhaps how often we see the children, whether or not we recommend fluoride. These are all things that are based on the Caries risk assessment. And so as we continue to talk in terms of bringing children into your dental practice, there is much that is going on that you can do in terms of counseling the parents that will be incredibly important. So there is one more question on the screen, so I want to make sure that I can cover that question. Will I review how fluoride impacts bacteria and affects sugars? Well, let me start with sugars because that is a little bit easier. Basically, caries form because you have three things in place. You have a surface, which of course is the enamel. You have a substrate, which is the bacteria, and you have food, which is the sugar. So when you have the fluoride going onto the teeth, once again, you are having a physically harder surface that will mean that it will be more difficult for the substrate, namely the bacteria, to take the sugar, which is the food, and create some kind of a flaw or carious lesion or decalcification in the surface of the enamel. So the effect that fluoride has on sugar is indirect but very substantial. The way it affects the bacteria is it will actually slow down the way that the bacteria is working on the substrate, or excuse me, on the food. So I do want to make sure that that you have the references here. Many of the articles that are mentioned here come from the American Academy of Pediatrics, the American Academy of Pediatric Dentistry, the ADA. These are all, so the discussions that we've been having during this program have largely grown out of references that you now see listed on your screen. There is a tremendous amount of science that is helping us to help parents help their children. In closing, what I really want to say is that my passion for treating children is because, unlike adults, children do not have the opportunity literally to care for themselves, especially at that time in their lives when they are so vulnerable. When they first get their teeth at 6 to 7 months of age, until possibly the time they actually go to school, they are not aware. There is no way that a child will understand the relationship between the Tootsie Roll and getting caries. So it is so vitally important that parents are instructed about these things, because parents care very deeply about their children. And I have never met a parent that has said to me, gee, I really want my child to have a lot of decay. So when you have parents that are motivated, you become the instructors. That is what doctor means. Doctor means teacher. It doesn't mean tooth fixer. And so this is a golden opportunity for you to provide your knowledge, which I frankly feel is the greatest gift that you can share with parents. Last of all, I did get a quick question that I think we still have time to answer. What is your experience with modeling? My experience with modeling is that everything I do in my practice is all about modeling my behavior. If I want a child to be quiet, I am quiet. If I want a child to be still, I will be still. If I get excited and upset, the child is more likely to get excited and upset. So the question is a very, very appropriate question, and I really appreciate this one. My experience with modeling is it is probably the key to behavior management. So in closing, I want to thank you all very much for attending. We're going to close with a quick survey. I will ask you to please provide feedback before you leave the session. And I want to thank you for being with me this evening for this brief 45-minute view into the importance of oral hygiene for the pediatric patient. And I want to wish all of you a happy holiday. Thank you.